There we go.
There we go.
All of a sudden, you're like, your podcast voice comes on. Okay, there we go.
All right. So, where are we right now, Whip?
So right now we're at the Toronto Pearson Airport, Terminal 1, I think, for Air Canada. We're going down to Saskatoon. And we've been planning this trip directly, indirectly for almost like 8-9 months now.
Yes.
Yeah. Have you ever been this excited to go to Saskatoon?
I have never been this excited to go to Saskatoon. Yeah. I hear it's snowing in Saskatoon, and
already, eh?
Already it's snowing, but and we're filming this because we are a little bit delayed because there's a fog situation.
Yeah, I mean, not be so harsh. Only about 2.5 hours, so it's not like ridiculous. It's very reasonable given Toronto and the fog warning and.
Fair enough.
Arrive alive, and
arrive alive. Yeah, we don't want to rush it.
Yeah.
Want to rush it. Yeah. So CSAM.
Yeah, so I thought it might be worthwhile just to share a little bit about what I like about CSAM, why I'm going, why I care about it, and a couple of the experiences there that I'm really looking forward to.
Okay.
So CSAM is the Canadian Society of Addiction Medicine, and it's an organization, nonprofit organization, mainly for physicians, although in the last 3 to 5 years, they've opened up to other healthcare providers to join. They've slowly changed their whatever agreements and all that kind of stuff. And I think I first went back in 2012 or 2013, maybe 2014. It was a while back because they had it at the same
8 years
weekend.
ago.
Yeah, they had it the same weekend at the Canadian Psych Association for a couple of years.
Okay.
And I went. It was in Montreal, and it was like a ISAM CSAM collaboration there.
And ISAM is the International Society of Addiction Medicine.
Yeah.
Okay.
Yeah.
Just clarifying for everybody here.
Yeah. And so the reason that I like it is, one, that it's very inclusive, right? So what does that mean? So in a lot of places, in order to get like some kind of specialty exam or certification, you'll have to do a couple of years of training. After a year of training, you have to do like all these criteria. But they're really about finding ways so that people out in practice can get this certification. So the ISAM has their own exam they can do. You just have to say that, hey, I've been working in the field for this many years, get a couple of references. And I think one thing that's been abundantly clear to me, and maybe it's to you as well, is there's not enough time to get fellowship trained physicians to work in this field. We have to have pathways for those out in practice. So that's number one. Number two is that when you start doing addiction work, I mean, it's different now, and also both of us were very much embedded in people that do addiction work. When you start doing addiction work, sometimes you're the only one in the hospital, the only one in your team. You're almost functioning on an island. And when you go to conferences like this, you hear from docs that have been working for 10, 20, 30, 40 years, and they've been on the island for a while. So all these problems that you're dealing with, like, oh, it's brand new, I don't know what to do, how are we going to get on-call coverage, what are we going to do about methadone prescriptions on the weekend, how are we going to get good pain management for somebody who uses drugs, how are we going to make sure that people don't leave hospital against medical advice. They've been dealing with it for decades. So number one is you don't feel alone. You get advice from people that have been doing it for a while, and then you start to hear stories that will allows you to find a way that you can continue to serve the most vulnerable, but also not burn out, not face moral injury, not face all those things that cause people to shift jobs. And for me, I think, especially because I was more trained in addiction as a psychiatrist, the addiction medicine skill set, the addiction medicine philosophy, I had to learn it through osmosis, through relationships with others, co-managing patients, figuring out that skill set, because I don't think it was fully there in my training, right? So I think for me, it's just about connecting with people that do similar or complementary work, learning about what they do, how they do, why they do it, and then getting ideas about stuff I can take back to improve the care that I'm providing on a day-to-day basis.
Yeah. So does every specialty of medicine have this? Like, is there a palliative?
Yeah.
Okay.
All of them do. But the thing is, addiction medicine historically has not been its own subspecialty. It's only the last 2 years or 3 years that the Canadian Family Docs Society has created a subspecialty certification, and it's only been about a year or so that there's the area of focused competence from the Royal College. So historically, it was just people doing this work at the side of their desk, right? So you'd have mainly family docs, but sometimes you'd have emerge docs, or you'd have like anesthesia. You have people that do addiction medicine. But back when I started, like at St. Mike's, addiction medicine Ontario was really just methadone. Then eventually they added methadone plus buprenorphine. Then eventually they added maybe some harm reduction. Eventually they added anti-craving medications for alcohol. And now it's at the point where a couple of hospitals have very high functioning addiction consultation services that offer the full breadth of addiction medicine care.
Yeah, so another gentleman we've talked about quite a bit is Bill Miller, right?
Yes.
And one of his little kind of kernels of knowledge is that addiction medicine is, maybe I've got this, I don't know if I got this right or not, but is one of the only areas where it's not given in primary care, right? It's sort of like a specialty in and of itself, but not provided in primary care. So it's like kind of like getting the silo of knowledge out, right? Not having this.
Yeah, and part of that is in the States, right? Because in the States they have very, very restrictive regulations on controlled substances, right? So I just can't start prescribing methadone. I have to have a special license, I have to be in a special clinic, I have to offer A, B, C, D, and E. There's regular tracking and auditing. And so in the States, even though they've had an opiate crisis too, they don't have as readily access to methadone, and different states have different regulations. So what Bill Miller is describing is true. It's not always the case in Ontario, and also in the States it's evolved a little bit with the addition of Suboxone or buprenorphine, right? And so in the States I think there's some places where it might be included a little bit in primary care.
Yeah.
But I think Canada has been leading the way with the certain clinics that do have both.
Great.
But you're absolutely right, yeah, historically it has been separate from it, and most family doctors historically have not offered that care, and they've not had the training or not had that skill set.
All right. Okay, well, I think that's it for now, and we'll maybe update people when we're at CSAM. Sound good?
Yeah, let's go. Let's not miss our flight.
All right, okay. Thanks, everybody.